Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for this program titled Eosinophils, Cytokines, and Clinical Manifestations of EGPA. This program is part of a CMEO snack series supported by an independent educational grant from GSK. I'm Dr. Michael Wexler, Professor of Medicine and Director of the National Jewish Cohen Family Asthma Institute in Denver, Colorado. I'm joined today by my colleague, Dr. Praveen Akuthoda.
Hi, Mike. Thanks for having me. I'm a professor of medicine at University of California, San Diego, and I'm a eosinophile. I take care of eosinophilic diseases and eosinophilic asthma. And I also do research in those areas, as well as at the bench on eosinophil biology. So it's going to be fun having this conversation.
Yeah, I'm looking forward to it as well. Our learning objective for today is to discuss and focus on the pathophysiology and clinical course of EGPA. So let's start off by discussing what is EGPA. EGPA is an eosinophilic vasculitis with several key features, including eosinophil-rich granulomatous inflammation, usually with eosinophilic vasculitis, moderate to severe asthma, and peripheral blood eosinophilia, with a lot of end organ involvement. Now, we can see manifestations of EGPA in most any organ system. EGPA can affect the upper airways with nasal polyps, allergic rhinitis, recurrent sinusitis, and otitis media, and it can affect the airways with asthma, eosinophilic pneumonia, and pulmonary infiltrates. It can affect the heart with cardiomyopathy, myocardial infarction, pericarditis, or arrhythmias. It can affect the GI tract as well with abdominal pain, gastroenteritis, intestinal hemorrhage, diarrhea, and many other symptoms. Oftentimes, this disease entity can also present with neurologic manifestations, such as mononeuritis multiplex, where patients can have weakness, tingling, and or numbness. It can also affect the kidneys with glomerulonephritis, and oftentimes it can also affect the skin with manifestations including rashes that can manifest as palpable purpura or an erythematous rash, subcutaneous nodules, or livedo reticularis. In many instances, patients just have a lot of systemic symptoms, including fatigue or malaise and fever or weight loss. When we think about how common and how frequent all of these symptoms are, I think it's important to look back at a lot of different studies that have evaluated the epidemiology of EGPA. And we recognize that asthma, sinus disease, and pulmonary infiltrates are very common presenting findings, as well as neuropathy. Almost all patients have asthma with eosinophilia, and then a large proportion present with what appears to be pneumonia or pulmonary infiltrates. When patients present, sometimes they have neuropathy with the weakness, and skin involvement with a cutaneous rash is also an important presenting sign. Praveen, maybe we can talk a little bit about the pathophysiology of EGPA. What is going on that leads to the manifestations of EGPA in patients that we see?
Yeah, let's start by talking about the eosinophils themselves and how they can mediate tissue damage. Eosinophils are complex cells with a lot of immunoregulatory features, but when you think about the direct tissue damage that occurs from and organ damage that occurs directly from the eosinophil itself, you tend to hone in on the cationic granule proteins that are housed in the many granules that are characteristic of eosinophils. And these cationic granule proteins include major basic protein, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. And these proteins are released when granules are released by eosinophils, and they can directly cause tissue fibrosis, they can cause thrombosis, and lead to damage in the airways, the blood vessels, the heart, etc. And then going back to this idea of eosinophils being complex immunoregulatory cells, while we think of eosinophils as a downstream manifestation of Th2 programming. Eosinophils themselves can perpetuate Th2 programming. They themselves contain many preformed cytokines and can perpetuate and continually activate Th2 activation. And when I say the words Th2, for those who are not familiar, that's the immunology speak for the canonical allergic inflammation that is mediated by the Th2 lymphocyte. And then kind of thinking a little bit about EGPA itself rather than the eosinophil, EGPA lives at the crossroads of two types of inflammation. Inflammation that's more vasculitic, perhaps Th1 and Th17 mediated, and inflammation that is more allergic or Th2 mediated. We're still learning, as you know, Mike, a lot about the immunology in EGPA, the immunopathogenesis, but it's still relatively early days, surprisingly enough. But I would say things to remember when you think about the immunology of EGPA are multiple pathways of immune activation. Th1 and Th17, again, potentially activating vasculitic pathways, and Th2 features perhaps activating the allergic manifestations of EGPA.
Yeah, no, it certainly is a complex pathophysiology. And I think that we have to think about this complex soup of cytokines that include not just the type 2 cytokines, IL-4, IL-5, and IL-15, but also the non-type 2 cytokines, including IL-2 and IL-17 and interferon gamma. Right? Beyond that, we also need to think a little bit about the downstream mediators that are observed, including, as you mentioned, some of the cationic proteins, but some of the downstream antibodies that are produced by B-cell activation. We're familiar with the allergic pathophysiology with IgE, but in EGPA specific, there can be production by B cells of IgG4 and of anti-neutrophil cytoplasmic antibodies. And so I agree with you, this is a complex situation. And what we're seeing is inflammation on multiple levels, at the tissue level, and then furthermore, more systemically, you can get a lot of interaction between all of these different mediators as well as antibodies. One of the key things that I think that we have come to recognize in EGPA in particular is the important role of the eosinophil. While we do have the antibody-mediated vasculitic activity, it's clear that the eosinophil is playing an important role in EGPA pathophysiology. And when we think about the eosinophil and how to potentially address some of the inflammation that is associated with eosinophilia, I think we have to think a little bit more upstream and look at some of the cytokines that are playing a role. And IL-5, I believe, is probably the most important cytokine for eosinophilic activity inflammation because it plays a role in terms of eosinophil differentiation in the bone marrow from stem cells, eosinophil activation, eosinophil survival, as well as eosinophil recruitment to the tissues, which is not just from eosinophils and IL-5, but also IL-4 and 13 play a role a little bit in terms of the trafficking of eosinophils. And I think it's really important to recognize the important role that IL-5 plays in patients with EGPA. And this has been borne out by clinical studies that have demonstrated that IL-5 may be increased in patients with EGPA compared to controls. And when you look at patients, their IL-5 levels can be higher, resulting in eosinophils being higher. And we also know that IL-5 is an important cytokine that's derived from both Th2 cells and ILC2 cells. So now that we recognize that IL-5 is important and that eosinophils are important in EGPA, Praveen, tell me what treatments have been developed that target IL-5 in general and specifically for EGPA?
Yeah, Mike, and even before I talk about those, just reiterate how important IL-5 is to eosinophil biology. So blocking IL-5 blocks all of those things that you talked about, the development of eosinophils from myeloid precursors in the bone marrow, the activation of eosinophils. So if you block IL-5, you're really blocking the presence and ongoing activation of eosinophils. So blocking IL-5 with monoclonal antibodies has been an attractive target for eosinophilic disease, including EGPA. And there are three biologic medications, so-called biologics, that are monoclonal antibodies against IL-5 or IL-5 receptor. Two medications that are IL-5 blockers, mepolizumab and reslizumab. Mepolizumab being a subcutaneous medication and reslizumab being a IV formulation. And as I said, those block the IL-5 cytokine itself from binding to the IL-5 receptor on eosinophil precursors and on eosinophils themselves. And then the third medication is the IL-5 receptor monoclonal antibody, benralizumab, which binds directly to the IL-5 receptor on eosinophils. And this is a little bit even more unique in that the binding of the monoclonal antibody to the IL-5 receptor doesn't just block the binding of IL-5 itself to the receptor, it actually engages natural killer cell function and engages direct killing of eosinophils by natural killer cells, so-called antibody-dependent cell-mediated cytotoxicity, or ADCC. So in theory, there's even better eosinophil depletion from the IL-5 receptor monoclonal antibody.
Yeah, and that's important. I think both of these mechanisms, either targeting IL-5 or targeting the IL-5 receptor, can have a significant impact on eosinophilia. And we've seen that in clinical studies when we look at severe eosinophilic asthma, with chronic rhinosinusitis, with hypereosinophilic syndrome. But really, at this point, the only therapy that is really targeting patients with EGPA that's been approved by the FDA has been mepolizumab. And that's, as you mentioned, a monoclonal antibody that targets IL-5 itself. So maybe we should review some of the data with regard to anti-IL-5 therapy and EGPA. The study that most people are aware of with EGPA is the MIRA study, which MIRA stands for mepolizumab in relapsing or refractory EGPA. And this was a study that was published in the New England Journal of Medicine in 2017. And in that study, patients were randomized to receive either 300 milligrams of mepolizumab on a monthly basis, or they received placebo on a monthly basis. Now, before that, one of the key outcomes was to evaluate the efficacy of mepolizumab in terms of reducing blood eosinophil counts. And in this study, it demonstrated a clear reduction in blood eosinophil counts in patients treated with mepolizumab versus placebo. But let's talk about and focus on some of the clinical outcomes in patients with EGPA. Praveen, you were part of the study along with me. Why don't you describe a little bit how patients did with mepolizumab treatment in the MIRA study?
Great. And I'll start by also saying that, Mike, you led this study, so you're being modest. And this was an important landmark study in EGPA and has led to a great deal of good outcomes in our patients with EGPA and life-changing outcomes. And that all stems from the clinical data in this study, as you mentioned. So the primary endpoints of this study were co-primary endpoints. They were the presence of remission at weeks 36 and 48, and then the total accrued weeks of remission. So if you look at remission over the course of the study, at all time points over the study, there are more patients with mepolizumab at any given week of the study who are in remission compared to those with placebo. And then when you look at the primary endpoints in the study, there are a greater number of accrued weeks of remission in the mepolizumab patients versus placebo, and a greater number of patients who are in remission at the end of treatment, and also at week 36 of the study. Those are some of the nitty-gritty details, but the top line message is that the study met its pre-specified primary endpoints quite robustly. And then other secondary endpoints of interest are, in particular, are the relapse rates or the number of relapses over the course of this study. And that figure shows about a 50% reduction in relapses of EGPA over the course of the study on mepolizumab. And we're now starting to see real world data emerge that track the efficacy data that we had in the clinical trial setting. And then as far as potential predictors of response to mepolizumab therapy, we're finding in post hoc analyses of these data that all groups, all comers seem to respond to therapy. It doesn't seem to be that any particular clinical indicators are telling us that one group of clinical features is more prone to respond than another. So it seems to be a pretty broad-based efficacy in patients with EGPA, which itself is a heterogeneous disease. So it's nice to see a broad base of outcomes.
Yeah, I think the other key outcome is really important to patients was the ability of mepolizumab to facilitate corticosteroid withdrawal in these patients. In the clinical trial, patients who were on placebo started off at around 10 to 11 milligrams of prednisone and really had no meaningful reduction in corticosteroid dosing. But in the patients who received mepolizumab, they were able to reduce their corticosteroid by about 50% and got down to 5 milligrams a day of prednisone. And as many as 19% of patients were actually able to come off of corticosteroids completely. And so that is, I think, unheard of previous to these studies in terms of EGPA. We also did a post hoc analysis evaluating other ways to look at the efficacy. The study defined remission as getting down to a Birmingham vasculitis score of 0 and a corticosteroid dose of 4 milligrams per day. And so that was one of the key definitions of remission. But we also looked at other outcomes, and that included patients who had no relapses over the course of the year, even if they weren't able to get down to less than 4 milligrams a day. And we also looked at the proportion of patients who were able to reduce their corticosteroid dose by 8% or more. And when we look at all of those outcomes, we found that as many as close to 80% or 4 out of 5 patients had a meaningful benefit in terms of some of those outcomes. And the other thing that I think it's important to recognize is just the safety data. This is a relatively safe drug, and it's been studied not just in EGPA, but in other disease entities as well, as have some of the other anti-IL-5 therapies. We should also mention, it isn't just mepolizumab that's approved. We're also doing a study right now looking at a comparison between mepolizumab and benralizumab, the IL-5 receptor antibody therapy, to see whether or not that is as effective or can be as effective as mepolizumab. But Praveen, what are some of the other benefits of anti-IL-5 therapy in patients in some other eosinophilic disorders? Where else have we seen some benefits?
Yeah, you can imagine that eosinophil depletion has got benefits in potentially multiple diseases. And eosinophilic asthma has really been the poster child for anti-IL-5, anti-eosinophil therapies. The landmark DREAM trial by Ian Pavort and colleagues from 2012 was the first positive study for mepolizumab in eosinophilic asthma, leading to its approval in multiple regions around the world for the treatment of eosinophilic asthma. And there's other studies as well that show corticosteroid sparing with mepolizumab that again kind of reiterate the clinical efficacy, including reduction of exacerbations, reduction of ED visits, et cetera. So eosinophilic asthma is one area. And other IL-5 therapies, including reslizumab and benralizumab, are also approved for the treatment of severe eosinophilic asthma. Mepolizumab also has another eosinophilic disease indication with hypereosinophilic syndrome. And we should mention that the dose of mepolizumab for severe eosinophilic asthma is 100 milligrams, while for eosinophilic diseases like EGPA and hypereosinophilic syndrome, the dose is 300 milligrams. But for hypereosinophilic syndrome, or HES, a phase 3 trial recently leading to the FDA approval did show a reduction in HES flares in this disease. And then the other disease indication that's been approved for a while is chronic rhinosinusitis with nasal polyposis, which again is based on robust phase 3 data.
So there's a lot of eosinophilic diseases that really can benefit from IL-5 blockade. So it's important for us to recognize these patients with eosinophilia. And when I think about eosinophilic diseases, certainly there's eosinophilic asthma, there's eosinophilic pneumonia, there's EGPA, there's hypereosinophilic syndrome, and then there is chronic rhinosinusitis, nasal polyps, all of which are eosinophilic disorders.
As part of this activity, we have two animations we'd like to show you. One is about the interaction between IL-5 and eosinophils in diseases like EGPA. And the second covers the mechanisms of IL-5 targeted therapies in eosinophilic disease.
Interleukin-5, IL-5, is a pro-inflammatory cytokine synthesized and secreted by cells of both the innate and adaptive immune systems. Sources of IL-5 include ILC2 cells, activated Th2 lymphocytes, and mast cells. The surface of eosinophil precursors and mature eosinophils contains IL-5 specific receptors. When IL-5 binds to IL-5 alpha receptors on the surface of eosinophils, it triggers several important effects, including eosinophil maturation, proliferation, activation, and migration. Eosinophils require a stimulus in order to migrate from bone marrow stores into the bloodstream. Exposure to IL-5 results in eosinophil egress into the intravascular compartment, resulting in blood eosinophilia and allowing eosinophils to mobilize to target tissues. In inflammatory disease states like EGPA, circulating eosinophils are drawn to epithelial surfaces or vascular endothelial sites of inflammation by a combination of cytokines, including IL-5 and eotaxins. IL-5 stimulates the degranulation of eosinophils. Intracellularly stored toxic granule proteins and cytokines are released that mediate allergic inflammation, thrombosis, fibrosis, and tissue damage. Monoclonal antibodies targeting IL-5 have been utilized to regulate eosinophil-mediated inflammation and tissue destruction. Pharmacologic neutralization of IL-5 decreases eosinophil counts and can lead to disease remission in EGPA. IL-5 monoclonal antibody binding disrupts IL-5 interaction with the alpha subunit of the IL-5 receptor, which is present on eosinophils and eosinophil precursors. Mepolizumab is an anti-IL-5 antibody that is FDA approved for treatment of EGPA and other eosinophil-mediated diseases. Rislizumab is also an anti-IL-5 antibody utilized in the treatment of eosinophil-mediated disease and is being investigated for treatment of EGPA. Monoclonal antibodies targeting the IL-5 alpha receptor are being investigated for use in EGPA. Anti-IL-5 alpha receptor antibodies bind to IL-5R alpha, preventing binding of IL-5 to the receptor. Additionally, the Fc fragment of the antibody binds to natural killer cells and induces eosinophil apoptosis via antibody-dependent cell-mediated cytotoxicity. Bemralizumab is an anti-IL-5R alpha monoclonal antibody approved for the treatment of eosinophilic disease and is being investigated as a treatment for EGPA.
But EGPA isn't just a eosinophilic disorder, it's also an ANCA-associated vasculitis. And I think it's really important to distinguish EGPA from the other ANCA-associated vasculitides, as well as just vasculitides in general. EGPA really fits into the medium to small vessel vasculitides that have been observed. You know, there's large vessel vasculitides like giant cell arteritis or Takayasu arteritis, and then other medium vessel vasculitides like polyarteritis nodosa and Kawasaki disease, and then small vessel vasculitides like cryoglobulemic vasculitis, Hanoch-Schönlein purpura or IgA vasculitis and hypocomplementemic urticarial vasculitis. But really, I think it's important to distinguish EGPA from the other ANCA-associated vasculitides. And those include microscopic polyangiitis and granulomatosis with polyangiitis, or GPA, which used to be known as Wegener's disease. So, Praveen, maybe we can talk a little bit about how to distinguish EGPA from GPA and MPA.
I think the eosinophilia itself is the main thing that distinguishes, these diseases. So that's not the only thing, but that's the main thing. Hypereosinophilia is really the calling card of EGPA. Eosinophil counts of at least 1,000. We could have a side conversation about defining hypereosinophilia as either 1,000 or 1,500, but for the purposes of EGPA, eosinophil counts of 1,000 or greater. The other things that I would distinguish EGPA from the other small vessel systemic vasculitides or ANCA-positive systemic vasculitides is the allergic features of EGPA, which you don't necessarily see present in those other entities, particularly the severe asthma. In GPA, you can have sinus disease, of course, but it's not necessarily allergic sinus disease like you see in EGPA. That can be hard to tease out clinically, but those are important distinctions. And then the ANCA positivity in EGPA really is much less frequent than in GPA or MPA. So best estimates in EGPA are that ANCA positivity is somewhere between 30 to 40%. And there are some large case series, including the French Vasculitis Study Group's case series that make this number probably the best one. Though if you look through the literature, you'll see numbers that are quite wide ranging for ANCA positivity, but I think you and I would both agree that somewhere around a third is probably the right number for ANCA positivity in EGPA.
Yeah, I think the other thing that is seen more commonly in GPA and MPA is the presence of glomerulonephritis. It does occur in EGPA, but not to the same frequency. So really, I think the key features are the presence of eosinophilia and asthma, and that's what really distinguishes EGPA from the others. And then the type of ANCA also. Patients with GPA predominantly have a C-ANCA type of ANCA or a proteinase 3, PR3 ANCA, whereas patients with EGPA usually have myeloperoxidase if they're going to be ANCA positive or p-ANCA positivity. So it's really important, I think, for clinicians to recognize what is EGPA and try to recognize it early on. And so to recognize, I think one has to appreciate how EGPA develops in a phasic pattern. Usually it starts off with a prodromal phase with asthma and rhinitis and maybe recurrent sinusitis. And then is usually an eosinophilic phase where people recognize some tissue infiltration or blood eosinophils as well that are elevated. And then it's finally the terminal vasculitic stage. And oftentimes that's too late. That's when patients already have all the manifestations of EGPA and they can present with organ involvement, including necrotizing vasculitis, neuropathic symptoms, glomerulonephritis, and or skin lesions. So it's important for us to recognize all of these in our patients. And it's the blood eosinophil counts that change over time that really allow us to make a recognition. And so we need to really take a look. People often don't look at the blood differential and look at the blood eosinophil counts. And we need to see the eosinophil counts because they can rise over time and might come down after treatment is initiated with either immunosuppressants or corticosteroids, which have for the most part been a mainstay of therapy. So when we think about these entities, can you talk a little bit, Praveen, about the difference in presentation between some of the ANCA-positive patients and the ANCA-negative patients in EGPA? What differentiates those patients?
There are things that tend to differentiate between ANCA-positive patients and ANCA-negative patients, but there are no, clear-cut dividing lines between ANCA-positive patients and ANCA-negative patients. So I think that's an important first point. There's no, absolute set of clinical manifestations that's going to absolutely track with ANCA positivity or ANCA negativity. But there are some tendencies, and some of the large case series, again, the French Vasculitis Study Group give us good data for which organ manifestations are more likely with ANCA positive versus ANCA negative patients. ANCA positive patients tend to be the ones that have more renal complications, glomerulonephritis, compared to ANCA negative patients. On the other hand, ANCA negative patients, they tend to have a higher percentage of cardiac complications compared to ANCA positive patients. Again, though, if you look at the numbers, you're not seeing absolute tracking between ANCA positive and ANCA negativity. For example, for renal involvement, about 33% of patients who are ANCA positive would have renal involvement, while 13% of ANCA negative patients would have renal involvement. And for cardiac involvement, those numbers are 14% for ANCA positivity and 32% for ANCA negativity. So these are tendencies, not absolute tracking between the two groups. And then one last point to circle back to what you were saying, Mike, about the potential phasic progression of EGPA. We've written this in chapters and articles that this is something that's classically seen and can be seen. You and I have both seen this pattern in patients, but it's not the only pattern that's seen. There's a wide variety of tempo with which clinical manifestations of EGPA occur. So you'll see all sorts of different patterns with patients over time. So important to point out that that's not the only way that you'll see somebody manifest their EGPA.
Yeah, really important points, Praveen. Let's just focus and go back on, what were our goals today? And our goals are SMART goals, our specific, measurable, attainable, relevant, timely goals, were really to apply the knowledge of disease pathophysiology to inform treatment selection in patients with EGPA. And I think we've done that. I think we've come to recognize that this is a complex disease, that the eosinophils are important, the vasculitis piece is important, and really that one should consider the use of IL-5 targeted therapies in the treatment of EGPA, as well as some other hypereosinophilic disease states. So thank you all for joining us. And thank you again, Dr. Ekathoda, for joining me today for our discussion. Take care, everyone.